I really want to get started because we have a really exciting and jam-packed program for you. I want to just start by acknowledging the absolute awesome faculty that have helped with putting this together. You will meet each and every one of them. I also want to acknowledge Dr. Brendan Visser and Dr. Nick Zaromsky, who were also part of the planning team. And of course, we have Dr. Attasit, who is the chair of education and training. And this was really put together by that committee. My name is Ellen Hagopian. I'm a hepatobiliary surgeon at Hackensack Meridian School of Medicine in New Jersey. And I'm the co-chair of education and training with Dr. Attasit. So just an overview. I know all of you received just the flyer and some instructions. When we decided to do this, we got together and talked about what are the things that we really want you folks to move away from your fellowship with. And we talked about, you know, the management of difficult cases. So what we did is we surveyed all of you and picked out the highest hits, the 3 highest hits, and decided at that point to really narrow it down into bile leak and post-pancreatectomy bleeding. We sent out some topics for all of you to think about, and also some resources to review it in advance. If you got an opportunity to do it, great. If you didn't have an opportunity to review the resources, they're there for you after these discussions. So today's layout will consist of starting off with a 5-minute, not even a 5-minute case presentation. The fellows will go into breakout rooms, and in the breakout rooms, you'll have a topic and questions, a series of questions of one topic to discuss. And after 20 minutes, you'll come back and we'll get together as a large group to discuss these the topics and the questions. Just like during the virtual fellows course, where we very intentionally put all of you into groups, different groups, so you meet different people. You will be in 2 separate groups for bile leak and for post-pancreas bleeding. You also are going to be in the breakout groups by yourselves. There's no faculty moderator. The feeling is that the group of you can collaboratively discuss and come to an agreement as regarding these the answers to the questions that we're posing to you. We will be posting things in the chat, such as the questions that we're going to be posing to your groups. So please don't worry when you get into your group. When you get into your groups, you will have those questions for discussion posted in your breakout group. Okay. So is Dr. D'Angelica with us? Okay, so perhaps he's running late. We'll have him, hopefully he'll join us a little later, and he'd like to say a couple of words. Okay, with that, I would like to hand it over to Drs. Amar Gupta and Dr. Ching-Wei Tzeng, who are going to speak on the bile leak case.
Thank you very much. Hello, everyone. My name is Amar Gupta. I'm a transplant and hepatobiliary surgeon at Baylor in Dallas. Thanks to Dr. Hagopian and Dr. Attasit for giving me this opportunity. The first case is posted here. So it's a 44-year-old female, no past medical history, no past surgical history, who presents to us with a couple of weeks of right upper quadrant pain. Cross-sectional imaging demonstrates a large mass in segment 5 through 8, taking up the entire right lobe, which is consistent with an intrahepatic cholangiocarcinoma. Further staging demonstrates no metastatic disease and the CA19-9 is low. This patient has no underlying history of liver disease nor hepatitis. Next slide, please. After workup and medical exam, she undergoes an open right hepatectomy. It ends up being an uncomplicated case with minimal blood loss. The case was done with extrahepatic inflow control and extrahepatic outflow control. The parenchyma was divided with the Erbijet, as well as titanium clips and silk ties. And the Glisonian pedicle was transected with an endo-GIA with a vascular load, and then oversewn with a 5-0 proline suture. And at the end of the case, there was no visible bile leak along the hilar plate, and there was no visible bile leak on the cut surface either. So that's the case.
Jill, would you like to just explain how to get into the breakout rooms?
Sure. Hi, everyone. Welcome. We are going to be using breakout rooms to facilitate small group discussion. So in just a minute, Dr. Hagopian will overview the topics that each room has been assigned. You'll find your room name by finding your last name and look at the room. We'll open the breakout rooms, and you're going to select the join breakout rooms, which you see there, where to find it in between by the reactions. Click on that. You'll see a list of 7 room options. Go into the room that you've been assigned. If you need help, just raise your hand and Margie and I will get to you.
Yeah, there's a raise hand at the bottom that's quite useful for times like this. So here, these are the breakout rooms. Please find your name and find your room number. We are going to post the names and the room numbers, these two boxes, in the chat. So if I move on and you haven't found your name, please look in the chat. And if you're still not sure, please raise your hand. Sound okay, Jill?
Sounds great.
Okay. I'm going to turn it back over to Dr. Gupta.
Okay, so this is topic A. And again, just to reiterate, this is for the fellows in rooms 1 and 2. So the questions that we had for you folks is, would you leave a drain in the patient that we discussed that underwent a pretty uncomplicated right hemihepatectomy? What intraoperative factors would affect your decision in this patient and potentially in other patients undergoing other sorts of liver resections? If you do leave a drain following a hepatectomy, what factors do you use to decide when to remove it? And regardless of whether or not you would leave a drain in this patient, what reasoning and or publication, data, literature would you use to support your decision? So again, this is for rooms 1 and 2. Topic B, this is for rooms 3 and 4 on the previous list. If you do not leave a drain in this patient, what clinical parameters are going to make you suspect of a postoperative bile leak? What's going to lead you to investigate? If you do investigate, how are you going to do so? What imaging and other modalities will you use? If you do a CT scan or ultrasound and you do see fluid, how do you differentiate from bile versus benign postoperative fluid? And if a bile leak or fluid collection is suspected on imaging, what's your next step? And the last question is, what is the role of interventional radiology versus a return to the operating room? And then for the last group, this is topic C. This is going to be for rooms 5, 6, and 7. What can we do to try to mitigate bile leaks? Have you been taught any mitigation strategies to reduce bile leaks? Are there any bile leak prevention tests that have been published in literature? And does the parenchymal transection technique, as well as the pedicle technique, affect your decision? So again, this is for rooms 5, 6, 7. When we come back to the large group discussion, we're going to have limited time. So please be ready to discuss what you guys talk about. If you want to assign a spokesman, that's fine, but we should get going as soon as we get back.
So here are the rooms again. It's probably best for folks to, at this point now, identify your room, go into your room. Margie and Jill are wonderful behind the scenes, like magicians, are orchestrating, posting those questions in your rooms. So when you get in there, settle in, take a look at the chat. And Dr. Shishrushka is in room 5. People should be choosing their room and moving into their breakout room. If there are any fellows left in the room, please raise your hand. And if you're having a problem getting into your room, please unmute yourself.
Hi, can you hear me?
Yes.
I managed to get in. Thank you.
Okay, very good.
Thank you.
Excellent.
Hi, I cannot get in. I don't see even the button to get in.
Okay, down at the bottom of your screen.
No, it showed up. Okay.
You see it? Okay.
Now it showed up.
You are, and you're room 3.
Yes.
Any other fellows having trouble?
Okay, all fellows are in the breakout rooms.
Okay. Dr. Ahmed is,
I think he's frozen. I see him.
okay. All right. I'm going to stop sharing just so we can see everybody. You know, we're always trying new things. And one of my colleagues said to me, we like built this whole new program, and I said, well, what do you think? Like, you know, what do you think about troubleshooting any problems, et cetera? And she said to me, let's just do it, and then we'll figure out what the problems are. So what I'm getting at is like, you know, we did give them a lot of questions, you know, let's see how things work out. For the rest of the faculty that are on, which is not that many. Hey, Brendan. Hey, Nick.
Howdy.
Hi, Sabino. How are you? Rohan. Hey, Flavio. I didn't see you there earlier.
I snuck in. Thanks for having me.
Excellent. Good. So you know, it'd be really nice to like, you know, eavesdrop on the fellows, right? But we're not allowed to do that.
You can go in and hide your camera. Nobody will know.
They can see you though.
Just change your name to Al Sadie.
No, but you can, Joe, correct me if I'm wrong. There's a way to go in with you in like stealth mode, like they don't see you.
Really? I don't know.
Yeah.
I don't know about that one.
Yeah.
Please tell me.
So if you like, I have to remember now. Is it? Hold on. I'm gonna stop my video. I should be.
The fact that you have this skill set seems a little bit upsetting to me, to be honest. You know that like you can crash other people's Zooms on stealth mode. That's not right.
I'm sure
Isn't that called hacking?
Okay, there it is. Can you guys see me now?
Well, we don't see your video, but we see your name.
Where do you see my name? You see
your name is right there.
No, there's a way to hide the name. Hold on.
You can't see me.
I don't know about that.
It's like a huge billboard.
I don't know about that. You know, I have to be honest with you. I'm not sure that. I would be surprised if that's a function, just because of all the like the Zoom hacking and things like that, especially. Oh, look.
Oh, there you went.
Well,
there you went. Now it's AHPBA.
Okay.
They don't know who you are.
Where?
You see, he's changed his name to AHPBA, so now they
Me?
know.
Right, but still, you know, it's. So on Friday, I was giving my students their summative OSCE, and they have to do this skill set. And so as soon as I like walk in the room, like we're videotaping them, but as soon as I walk in the room, it's like all of a sudden the sweat starts going, you know? So, I mean, I think that staying out of the room is probably best.
Yeah, this is why we always ask at tumor board, who's call-in user 3? Right? That's always...
Okay, we've got.
I like that, Ching-Wei. I'm just gonna close my eyes.
Yeah, right, like this. So, Jill and Margie, are things going okay? Do you need me to help?
No, everything's going great.
Okay, we've got the questions posted, etc. So just refresh my memory. I was watching the clock. It looks like that we were maybe just a couple of minutes late. We were supposed to start the breakout room at
5:13, and we're gonna end ending it at 5:33.
Okay, so at 5:33, so it actually 5:30, you can put across a banner saying, you know, you have 3 minutes left, and in 3 minutes, you're just going to be brought back. And I would just immediately bring everybody back, even if they're mid-sentence. So.
Sounds good.
All right. So thoughts from, you know, other folks who were not on the planning committee of how we set things up. Any feedback from you folks?
Well, I hadn't seen the topics for the Bile leak paper, but they look great. Whoever put those things together, I think that this is a very solid job.
It was a group effort, so yeah.
It's a great debate, the whole drainage thing, I think. I mean, we don't have time to go into all that, but I feel like it follows what people have been talking about pancreas for a decade before, right? Like now it's like talking about liver. And if you look at the NISQIP data, there's actually a paper that just came out today from Ohio State from NISQIP update. It's literally half the United States puts a drain and the other half does not. So it's really half and half. It's very interesting. So that's why I want to let the fellows say what they do at their institutions and defend, not that it's right or wrong, but defend why they've been told to do a drain routinely or not.
Ching-Wei, are there geographic patterns?
They didn't show that in this paper from Tim Pollock's group. It was just mainly talking about how even though half the people have drains and a lot of them have a drain bilirubin on day 3, they still ignored the drain bilirubin. So even if the bilirubin was low, they still left it in. So only 6 out of 7 people still kept it way late. It's just like the pancreas data. People get a drain fluid amylase and just still keep the drain anyway. And so.
Oh, that drives me crazy. Why check it?
That's interesting.
Right.
So 50% of people are wrong. That's incredible.
Yes. We're trying to trigger that reaction. Exactly. Right. You summarize it after they talk. I'll just let you summarize. You're all wrong.
The older I get, I realize that there is no one way to do anything. And if anyone tells you that something is wrong, they haven't done enough cases.
That's right. That's right.
Well, it reminds me, is Mike on yet or no? I don't want to quote him by saying, but there was an old saying, when we were fellows, that there's the right way to do it, the wrong way to do it, and the memorial way to do it.
I thought you were going to say in the way I do it.
Yeah, exactly.
The right way, the wrong way, and the way I do it.
Same thing, yeah, exactly.
Well, that's one of my other mentors who used to say, you can do it my way or I can do it my way.
So Ellen, I just wanted to ask you about, just so that we can be, like you said, we're trying something new. I just wanted to make sure, I do think it would be useful for at least Jill and Margie to pop into these other rooms and just make sure that there's not silence, because it's possible that they could take 2 minutes and say, well, this is what we do, blah, blah, blah. This is what we're going to say, end of story. And I just want to make sure that we're using this time effectively for them, because I do think that sometimes without a facilitator, it can be challenging.
Yeah, I mean, you would hope that, they're all adults again, and they're not, they don't have to be told to have the discussion. But yeah, Jill and Margie, you want to just kind of fly in and out and just say, everything going okay? Okay, bye.
Sure, no
You know,
problem.
Like if there's active discussion, then you don't even have to say anything.
Yeah, actually, it would be great if you don't say anything and just maybe take some notes from each of those sites. They'll think that it's just an administrative thing, but I really do think as we're learning, because to let self-facilitation occur, you really want to make sure that it's happening, right?
Yeah.
And so with them just being like, listen, I'm just going to go on YouTube for a while and come back at the end of this 20 minutes would be a shame.
Sure, no problem.
You can log in as AHPBA, like I'll say.
You could log in as Adnan Al-Sadi.
Well, we're of course we're going to be, sending out evaluations afterwards. So, we'll be getting the feedback of our constituents, right? So, any other thoughts?
So just confirming, you want me to go pop in the rooms real quick and come back?
Yeah, just pop in, make sure that they're not like dead silent and
Give us a temperature check, Jill.
Sure, no problem. Stand by.
We say in the fashion world.
Yeah, we do.
If it's high output, I'll leave it some time to try and see if it decreases by itself, within 5-7 days. If it's not, we'll go to ERCP as well.
Loss, if y'all lose it, have a more than average amount of blood loss, does that affect your decision? I think that's the only case where we've left it.
Wedge resection or like parenchymal spiral resection for a tumor. Usually that's what's happening. Yeah. Hi, Jill, we're by ourselves here.
Hi, just making sure you guys are okay.
Yeah,
we don't have a faculty with us, so we're just talking between each other. That was supposed to be?
Oh, yep, no faculty. It's just fellows. So,
no faculty.
Yeah, no faculty. Yeah. So you'll do you have the topics that you are supposed to be talking about?
Yes.
Perfect.
Yes.
Awesome.
Yes.
So after at 5:30, so in about 6 minutes, you'll be brought back to the main room, and one of you will have to tell everybody what you thought.
Okay.
So you have plenty of time. You have 6 minutes to figure out a response.
Okay, cool.
Okay. Enjoy.
Thank you.
Okay.
Yep. Bye, guys.
So answering.
And then we got embolized, and we'd like operated on like months later, but the tumor was stuck to the table, and that was tough because
just feels like it's kind of, well, for the technique it's nice, but it's still two different fields,
Yeah. I think Jill has joined us.
Hi guys. I just wanted to make sure you're doing okay.
We are.
Yeah, we are.
Is there any way we could get
Dr. Brenda Moore?
Sorry.
Hey, hi.
No. Good.
Sorry. Is there any way we could get a copy of the question?
Yeah, for sure. Let me give it to you. Hang on one sec. Okay, so you guys are room. I just popped in here, but
I think we're 6.
6. Okay. Yep. So here are your questions. And then just as a reminder, they are going to call on your room to answer these questions or answer one of these. So you'll want to have something prepared to speak back. And so I'm going to close the rooms a couple minutes after 5:30. So you have a few minutes. So I'll get out of your way so you can get to it.
Okay.
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 Let's see.
Yeah, I feel like if you're doing CUSA and that meticulous dissection where you literally like see every single little detail, you're using your loops, you're clipping everything,
Sure.
you're not gonna be worried about. But there's some surgeons who just use a ligature, right? Just ligature, and then when there's that big
Have in their set their slides to go over at the end, but yeah, it's a balance. Jill, you want to give us a
Well,
recap?
I've returned from my spy mission, and I'm happy to report everybody is doing awesome. There was one room that was confused and thought a faculty member was joining, so it was a good thing to pop in on them. But otherwise, everyone's doing great. Really good discussions, and it all seemed on topic.
It's really amazing because I did say that, right?
Yeah, you did.
And there were like 6 or 7 people who were in the room, all heard me say this. And none of them
and they
really
all
did.
have their cameras on too, which is so great. So they're all looking at each other, and yes. Anyway, all good.
Did you watch that clip? And it's kindergarten, and the teacher somehow drops off, and the kids start like talking about, and they're like afraid to say something like bad because they're like, no, she's still watching us. And the other person's like, no, she's not here. And it's like the funniest thing.
I would just like to thank everybody for joining. I mean,
awesome.
Gosh, it's amazing. Like, I hope the fellows realize that, like, the amount of firepower of hepatobiliary surgeons who are on this Friday afternoon call, really, because we really are all committed to educating them. Yikes. Ellen, obviously you did a huge amount of work, and the other people who really put together the slides, but it's just really such a nice show of the commitment of all of these sites and all of it, and everybody as educators here.
Yeah, I agree completely.
Yeah, well, I just, everybody on this call is just amazing. And the whole panel was just, amazing. And you were part of it too, Brendan. So yeah,
Well, and I just want to
Take the
say, I
team.
mean, just speaking for the AHPBA, and I know Jill and Margie have said this, this is so important because this is one of the major things that we do is train HPB fellows. And really, I appreciate the leadership here for showing that by putting boots on ground and actually showing that, because we don't always do that. And I think that this is great. So thank you again for, speaking on behalf of the AHPBA.
Okay, well, that's up to you, Adnan. I am so much not a social media person. I wish I were. We'll leave that up to you to tweet.
I've been bitten. I tweeted a Zoom picture, and there was some medical students, and then they're like, I didn't have their permission to tweet. I'm like, are you kidding me? It's like a Zoom, for God's sake. Anyway.
It would be nice if folks can very briefly turn their camera on, and then someone can take a screenshot right here.
Yeah, let's do it.
The faculty, that would be fun.
Yeah, I can take a picture and then I'll
And you have my permission to tweet it.
Oh, thank God. Oh my God, I was really worried about that.
Don't you have kind of a man as a celebrity? Don't you have a manager who kind of controls your image? And
I do have a publicist and a stylist.
Right. And like the sponsors and the sponsors
Kathleen,
want to
put your camera
control
on.
how it gets disseminated.
And is that, I'm
Kathleen, we
assuming
need
that
you.
is David masquerading as Blair, because Blair's
Blair's
works
his
with
assistant.
David.
I am on, but no David. So I'll let you guys shine. Yeah, I'm just a silent observer and just seeing how you did this, Ellen. It's running great.
All right, everybody, look at the screen. Smile. Look good, Flavio, for once in your life. All right, got it.
Yeah, well, thank you for the warning, because I think that there was some sort of a screenshot taken of us doing something, and boy, we all looked awful. Rohan's looking down. My hair is lopsided. Somebody else is like looking off in the sunset. It was not a very good picture. I forget where it was. So thank you for letting us know before you took the picture.
Sending it to you, Jill, if you don't mind.
What's that?
I'm just sending it to Jill.
Oh, okay.
Yeah, that'd be great. We'll send it out through HPBA's Twitter account.
Good. So we have about 2 more minutes before the fellows are just going to be booted right back. Jill, you're going to put, a banner up, let them
Yes,
know.
it already went out. We can't
Morning.
see it here, but it went out to the breakout room.
Okay.
Had a good turnout.
I'm going to start to share my screen. I'm sorry, Ching-Wei.
No, I was just saying a good turnout with the fellows. I was looking at the whole list here. Okay.
Yeah.
Pretty good.
Yeah, that's awesome. So I'm going to start to share my screen. So Amar, take it away as soon as they get back. It's both you guys' show, okay?
I think Ching-Wei, you're going to go.
Yeah, I'll start. Yeah.
Okay.
Okay, fellows are in their last warning. They'll be back any second.
All right, great. I think we have everybody back. Welcome back, fellows. I hope you all got a chance to meet each other. That's probably the most important thing. And the second thing was to talk about your topics. I'm Ching-Wei Tzeng. We're going to talk about topic A first for rooms 1 and 2. So for topic A, routine drainage over hepatectomy, probably one of the most controversial things. I'd like to hear the feedback from room 1.
Yes, hi, this is David Badgerton from Halifax, Nova Scotia. I'll speak on the behalf of our room. So for routine drainage, questions we had was, would we drain the patient that was described? And our common answer was no. We would not drain this patient. What intraoperative factor would affect your decision on placing a drain? Well, the first was going to be was there an obvious bile leak when we did the operation that we tried and repaired, and if that was the case, we'd probably drain in that case. If the resection was anatomical versus non-anatomical, there was a higher chance of us draining if it was non-anatomical. Major blood loss was also a reason for probably drainage. The other reasoning for drainage or no was how difficult or complicated would the leak be afterwards, especially in meanings of IR axis. How complicated would an IR drain to be placed in a patient? We're thinking specifically for right posterolateral sectors resected, isolated segments 7 and 8 as well. If we leave a drain, how do you decide to remove it? Well, then that's where probably we had more of the surgical voodoo and experience and training in there, where if we leave a drain and it was in between post-op day 2 and 4, if there was no bile in it and the patient was eating and doing fine, that's probably when we would remove it. The reasoning and data for our decision, well, for the reasoning, I think I spoke a bit on that. For the data, well, certainly if the data available that we all were aware of is that a drain versus no drain approach was made no difference in the incidence of leak and barely difference for mitigation of leak as well. RCT from, we were not sure if it was from Korea or Japan, a recent one, showing no difference in between drain and no drain, as well as several other case control studies and case match studies. So that's the data we're aware of to suggest the drain no drain approach, and given the low incidence of leak, we certainly would base our decisions on these data. Yeah.
Okay.
Why am I losing teeth so
Thanks for thinking through that. That's very good. I would say that the only correction I would say on that randomized trial from Japan is that there is a difference in the fact that there's more leak in the drain arm. So it's not that it's equal. There's actually more in the drain arm. But
yes, my mistake. I misspoke. Sorry.
No problem. So room 2, what are your thoughts?
I think, sorry, let me go back to the questions, but whether or not we routinely leave it drain, there's a little bit of a differences between everybody's answers. For the most part, everybody said, no, you shouldn't, but in practice tend to leave more drains than in reality, probably leave more drains for reasons. If you have an ongoing bile leak, if you had more blood loss, but biliary anastomosis in the case.
Okay, I think that's a fair point. I think there's probably some survey bias. If you ask most people, you probably get the idea that no drains are ever placed. But if you look in NISCOP data, what % of people do you think have a drain placed in the United States, if you had to guess?
30.
It's about 50-50, in fact. Yeah, 55-45. So it's a coin flip. So, people will answer the way they think you want them to answer and say, well, I don't put in drains. But in reality, like you said, often people will leave drains. So it's a very interesting dynamic. I think before we move on to topic B, I want to hear from the other faculty on the call if they have any other thoughts on this drain versus no drain for routine hepatectomies. Adnan, did you have something?
No, I think it's summarized it nicely. The only thing I would love to know what people think is, and I mentioned this only because there are rumors out there that people talk about a lot, and who knows what's true and what's not. But in terms of does laparoscopy give you more confidence not to leave drains? Now, I think we should probably just put it on the table. Like, I think most sane surgeons, if you have a biliary anastomosis, will leave a drain. We're not talking about that. We're talking about straight livers. If you have a straight liver, does visualization under magnification, whatever, does that help you, be more confident to not leave a drain? Less blood loss? I don't know.
Yeah, I like what the first group talked about, how they thought about the size of the resection, the transection surface. Even I think people think about how they either use a stapler or what kind of technique. Any other thoughts from the faculty?
Well, I was just going to jump in and say that obviously the trial is not new. The trial has been done a while back. So the topic is obviously ongoing. What I would say is from a practical point of view, the reason why drains don't necessarily, quote unquote, prevent leaks is that drains, especially after livers, it's like putting a drain in the peritoneal cavity. It can be in the pelvis by the time you close. So just keep that in mind. It's not necessarily where you think it is.
Ching-Wei, this is Rohan Jayaraja. I just wanted to point out that I think one of the other issues is if you've got a patient with underlying liver disease, I would actively not want to put a drain in that patient because I never know when to take it out because I'm draining ascites. Second of all, our practice about 5, probably 6 years ago was to stop placing drains in any major hepatectomy.
Yeah, good points. Well, in the interest of time, I appreciate all the feedback. Let's move on to topic B. Amar?
All right, thank you, Ching-Wei. So topic B, this was for rooms 3 and 4. So room 4, why don't you guys go ahead and tackle the first 2 questions, and then we'll pause there. Is there a spokesperson from room 4 or anyone who wants to?
I can take it. I'm Tash, I'm the WashU fellow. We don't leave drains in any of our liver resections actually. And we actually use ICG and we find it quite helpful to evaluate for bile leaks too, just as a separate thing. If we do not leave a drain, what clinical parameters make you suspect a post-op bile leak? Change in clinical status, new abdominal pain, fevers, new abdominal tenderness, changing labs, maybe LFTs or white count going up consistently, something like that. And we would typically start with a CAT scan and see if there's a fluid collection in the right upper quadrant or, something that looks suspicious for a bile leak. And that'd probably be our initial imaging test. And then, based on how the patient looked, we would either have IR stick a drain in it and confirm that it's bile or potentially do a HIDA scan to confirm a bile leak.
Okay, is there anything that would make you rest a little easier based on the patient's clinical condition if you see a little bit of fluid on CT, if you're thinking maybe just post-operative changes versus biloma?
The density of the fluid, I guess, whether it looked more like seroma and just simple fluid or whether it was more complex fluid.
Okay, perfect. And how about someone from room 3 to talk about what you're going to do in terms of management and the role of IR versus operating room?
Hi, good afternoon. This is Antonio Masi from McGill. So first of all, as we say, the flu seen on CT scan, how differentiated, as we say, the Hounsfield unit generally less than 20. And then obviously when we have a suspicion, unless there is a super infection concern of the presence of bubble or not, this gives the idea the disease is more complicated, likely with the biloma. As we say, sometimes it could be helpful CT cholangiography or in adjunct the MRI with specifically biliary contrast excretion. In that case, if the patient has a change in clinical course, so we can consider that like a type B bile leak according International Study Group classification, we would like to, as we say, we confirm with MRCP, and we can use ASK-IR to put a drain and getting a sample with that, sending for culture and for specifically biochemical aspect of the collection. Most of the time, if the drain is sufficient, having and dries up, so we have a source control of that, we would not proceed with the further intervention. But if there is a persistency in amount of the output of the drain, or in clinical scenario of the patient, so the increase of white blood cell count, persistent ileus, decrease functional recovering postoperatively, then in the case we need a better source control. In the case with having an ERCP with the sphincterotomy would eventually help. The last source, we have a high output of the fistula, non even controlled with ERCP, and neither showing a patent. In the case, the last options would be going back to the OR, considering the fact that going back to the OR after 15 days makes it not only more difficult to identify, because the source of infection of leak is very hard to identify, even with a direct intraoperative study. And the second point, the capacity to heal is very complicated. So, and this mostly associated with part of the ischemic or no identified bile. So we think that ERCP combined with IR most of the time resolve the situation, and OR should be more dedicated with sepsis uncontrolled and worsening the clinical scenario of the patient.
That's terrific. I think that both Tash and Antonio, you guys hit all of these points kind of on the head that we were looking for in terms of the teaching points that we wanted. I think that any deviation from what is considered, the normal post-operative recovery of a patient should alert you to the possibility of a bile leak. So exactly what you said, worsening in clinical status, pain, fever, abnormalities. In terms of imaging, I get the sense that most people would use cross-sectional imaging, although I'd be interested to see how many people would start with an ultrasound to see if there is any a large volume of fluid in the resection bed. In terms of differentiating whether or not this is normal or not, I think, again, this just goes back to clinical scenario, as Tash said. Is the patient having fevers, or is their bilirubin mildly elevated? Is there anything out of the ordinary? With regards to next steps, I think most people would agree that interventional radiology to drain it is both diagnostic and typically therapeutic in the majority of cases. And in those where it is a large volume and it doesn't stop, then I think ERCP is definitely the way to go. And return to the OR, this is something that we discussed as a group, and I'd be very curious to see what the faculty think about this. I've never seen or had to take anyone back to the operating room, but I definitely have a significantly shorter amount of experience than the faculty does. But our general feeling is this is really reserved for those patients that are septic. This is not necessarily to control the bile leak itself, because as Antonio mentioned, locating it was going to be very difficult and potentially dangerous. This is more that patient that has infected bile peritonitis, and this is more source control. So real quick, I'd be very curious to see what the faculty think before Ching-Wei takes it home with the third group.
Just in the interest of time, Dr. Gupta, we have maybe about 6 minutes left. So just for time management, but go ahead, faculty.
I'll jump in. Usually I would really only take the patient back if I was worried about an associated bowel injury, because sometimes you can see bile in that circumstance. I also put in the chat just the use of air cholangiogram, just to discuss that. And then also remember that MRCP with EOVIST on delayed phase will give you a functional study too, because you'll actually see bile extract.
I think that's probably a pretty good lead into the third group, Ching-Wei.
Yeah, great. Yeah, I think that topic C, mitigation techniques, is very important, because it's quite obvious when your white count is 20 on post-op day 6 and 7, but guess what? They're not in the hospital anymore nowadays. So what can we do to prevent the bile leak from happening? So I want to hear from room 5 first. What are your bile leak mitigation strategies you've been taught in your hospital? Group 5.
I'll pipe in. It's Sean from Toronto. So I think, one thing that we talked about in reducing bile leaks would be a good preoperative imaging to identify any aberrant anatomy. So in a case like was described, looking for a right posterior coming into the left duct that you want to anticipate ahead of time. And then one member of our group says their center tends to use the air cholangiogram, which I think is described by Andy Anderson, and using the cystic duct to do an air cholangiogram and test for a bubble leak. He described that they had noticed a few bubbling during some of their cases that they oversewed, and said it did well. So the rest of us hadn't done that before, although we'd heard it described. We used more of a crude, clean lap pad on the raw liver edge to check for bile, and then obviously if something was identified, would be oversewed and leave a drain in that case.
Sure. All right. Group 6.
This is Yasmin and Russ from Virginia Mason. We totally agree with kind of what Sean said as well. Sometimes we have seen ICG used as well, as Tash mentioned, to try and pick up on any bile leaks intraoperatively, but otherwise really just laying down a clean right tech for a few minutes. I've personally never seen the white test or the air leak test or methylene blue used, but those are also described in the paper as well. And then the only other thing that Alex was in our group as well from UBC, we were talking about just a careful parenchymal dissection technique just to try and identify your structures and clip them.
All right, that's good. Yeah, there's nothing better than careful parenchymal transection for sure. Group 7.
I can speak for group 7. I mean, we kind of discussed the same. I think the air leak test is done at many institutions. Obviously, it was described at MD Anderson, and some of the surgeons who were trained at MD Anderson do that. But the majority of surgeons would leave the lap pad for a few minutes, and then look for any bile, and then try to put Prolian sutures in any if there's any evidence of bile leak. And then for the parenchymal transection, again, if you're using the CUSA and you're doing meticulous dissection and kind of clipping instead of just using kind of like a energy device, then you're more likely to have control. The other thing for prevention tests, I think sometimes stapling the pedicle and then oversewing it, that's another technique that we have discussed as well.
That's a good point. Yeah, I think, when we started using the air cholangiogram test around 2010, 2011 at our institution, the most common area for a bubble was at the staple line. We don't see that too much anymore because we learned from our technique that we need to sit on the stapler longer. I think that was the problem, right? A lot of people, that's the final step, right? To divide the hepatic duct on that side and you just put it on and fire away, and the beads aren't forming on the stapler. And so we used to suture it, but now we rarely see it. But if there is a leak on the air leak test, that's the most common place nowadays. So hopefully people can get an idea of that. Just for wrapping up, I won't go into it too much, but it's a pretty easy technique that I know I'm biased to describe it, obviously, so I'll save my bias. But you just intubate the cystic duct, inject air, and just put it underwater, just like you do a rectal anastomosis type bubble test, very easy. And you can fix it under clear water, in fact. So it's a very easy test if you have a cystic duct available to you. And it's not messy. One of the reasons we use that instead of like some people use methylene blue is that you can inject until everything is fixed up. I want to hear from the other faculty. Any other thoughts on any other bile leak mitigation strategies? Because I think we have one more minute. Rohan or Sabino.
It's Brendan here. I wanted to touch base about what was CUSA and about Rohan and Adnan's. So I'm a CUSA liver surgeon, and I think that, following from the French, that's the way liver was meant to be divided by God and the French.
Right, exactly.
So anybody who does anything else, I think, is inferior, all the memorial people especially. But with that bias, the only randomized controlled trials that demonstrate a difference, don't demonstrate differences in almost anything except for using a ligature did decrease bile leaks over a crush clamp. So I don't know that, I think meticulous technique matters. There is not data that says by itself a CUSA is reducing your bile leak rate. And in fact, those who use something like a ligature might have some small amount of evidence to suggest that a vessel sealing device might help with small bile lux.
But Brendan, to that extent, you know, I think the problem is that when you're using a technique, if somebody's using a technique, like for example, if we're using staplers to go through parenchyma, it is so, you know, kind of, there's a lot of oozing that it's actually almost impossible to know if you have a bile leak or not, as opposed to the CUSA. And I think that's kind of where I think the benefit is. And I guess we're in the same boat, but anyway, I was just going to point that out.
I was just going to suggest that to put in a plug for Dr. Maker and his, I think he's got a session on parenchymal transections at the meeting. So I think this will be something to discuss there as well.
Yeah. And I'm just going to say, I really think it depends on how you use the stapler. People take 2 big bites with the stapler. That's the issue if they use staple technique. Exactly. But that's my own bias because they always get more in the end than in the middle. I'm going to stop talking.
Yeah, well, that's what I agree with Brendan. Infrequently do I disagree with Brendan, but I totally agree with Brendan from the Europeans and how they do things. But yeah, it all comes down to technique, right? I'm gonna give Dr. Gupta and Dr. Tzeng 30 seconds before we move on.
Yeah, so first of all, thank you very much to the faculty and all the fellows. I think this was, I hope this was beneficial for you. We just wanted to very quickly summarize some of the teaching points that we thought were important. It sounds like the majority of fellows are not necessarily leaving drains in routine, uncomplicated hemihepatectomies that are anatomic. We think that there is some data to support that, the most recent being the trial in Japan. It sounds like everyone kind of is on the same page in terms of when you leave a drain. Biliary anastomosis, I think, is really kind of the big one there. If you're doing a hepatic vaginectomy, especially intrahepatic, those people should have drains. And most importantly, if you are going to leave a drain, have a plan in terms of when you're going to remove it. Don't just put it in without a plan, have some kind of strategy. With regards to management, I think the fellows did a fantastic job on this. Typically, you source control with IR drainage. If they need further source control, I think stenting is the way to go, typically endoscopic if it's feasible. And as some of the faculty pointed out, the operating room in this case is really reserved for those patients in septic shock and extremis. And then
maybe frozen.
As Dr. Tzeng pointed out, with regard to deal with it. So I think that's very important.
Okay, great. All right, thank you so much. Let's move on. We are really keeping to time. So the next case that all of you fellows wanted to hear about was post-pancreatectomy hemorrhage. And I have the great pleasure of introducing to all of you Dr. Attasit Chokechanachaisakul and Dr. Kathleen Christians, who are going to present the next case.
Okay, this is a case presentation. The first one, this is the only one, sorry. There's a 70-year-old male. The patients had presented with the obstructive jaundice and then was on the workup was found to have pancreatic adenocarcinoma. Underwent a chemotherapy full course with RT, and then restaging CT show interval decreasing in size of the mass at the head of pancreas, but still has persistent portal vein involvement. There's no metastatic disease that detected. CA19-9 is low. He has no underlying coagulopathy. Next slide, please. Underwent a Whipple operation with portal vein resection and reconstruction. We did enterococci PJ anastomosis, enterococci HJ anastomosis with loop gastro J, minimal blood loss with left JP drain, hemostasis at the end of the case. And Kristen, and then Dr. Kristen can go ahead.
So as in the first scenario, you each have your varying breakout rooms, and remember that these are different this time. So find your name and figure out which room you are headed to after the questions are given to you.
And again, this will be put into the chat. Jill and Margie will do that. So if we move on, and as we talk about the questions, just look in the chat. And if you have a hard time finding your name, just please raise your hand.
So the questions that we'd like you to think about in topic A, so groups 1, 2, and 3, early or less than or equal to 24-hour postoperative bleeding with hypotension. What is the cause? What tests do you need? What are the treatment options? When do you decide to take them to the operating room? And what intraoperative methods or techniques can you use to ensure hemostasis to prevent this complication? Next slide. Topic B for groups 4 and 5, late post-pancreatectomy bleeding, so more than 24 hours. What's the most likely cause? What diagnostic tests do you need? What are your treatment options? If you choose to use interventional radiology, what kind of techniques should be utilized? Next slide. And finally, topic C for groups 6 and 7, post-pancreatectomy GI bleeding. What's your most likely cause? What's your differential? What tests are needed? And how can you treat this problem?
So again, here are your groups. The staff will post your questions in the breakout group. So please go ahead and choose your breakout room, which is different than your previous breakout room. And you'll have 20 minutes to discuss your topic questions. Let us know if any of the fellows are having a hard time finding your names or moving into your breakout rooms, just by raising your hand.
Looks like
All fellows are placed.
Wow, that was good. Seamless.
That's awesome. See, we just you got to just do it, right, guys? And then we figure out what the problems are. I think that went really well. What do you guys
think? That was great. I was really concerned, but I thought that was great. They just need to have a spokesperson for each room so that they know somebody.
I can't believe that they didn't figure that out.
Yeah.
What?
I was pretty impressed with the fellows, actually. I think they did a tremendous job.
Yeah, they did great.
Yeah.
Yeah. Good. Okay. And I think that Jill and Margie are probably, putting those questions in the chat in the rooms for the fellows.
Just a quick question for the group. Are you guys in synchronous metastatic colorectal cancer? Are you guys using FOLFOXIRI routinely or FOLFOX?
We only use FOLFOXIRI for conversion therapy. People who are unresectable really just, they need a kitchen sink to convert down to becoming borderline to get to a 2-stage or something like that. Because if you throw the kitchen sink at them, it better work in 4 cycles. Because once they get to 6 or 8, their liver is going to be dead with the FOLFOXIRI, so.
I was just wondering what you thought about the new EPOCH trial.
Hi, guys. Just wanted to make sure you have your questions.
Yeah, I think we can see them on the chat.
Perfect. Okay. So it's going to be just the 2 of you in this room. So feel free to get started and we'll see you back at the end of the time.
Okay, thanks.
Thanks.
Okay, so I guess it's just
we all are on the same boat, just to say it. Resuscitate with blood products or volume as needed. And my first
hypotension. And so what's the most likely cause?
Probably. Well, usually like suboptimal hemostasis, or I don't know. In this case, that
maybe it was like a named once, if it's a named vessel, fine, you end up finding it because it's still squirting in your face, but a lot of the time it's not.
Would you hi Jill,
I just wanted to make sure you guys are okay.
yeah,
we are. I think our friends are not coming, so
I don't think so. I think it's a party of two, but enjoy and we'll see you back.
that's okay.
Okay. Bye-bye.
all right. All right. So I think the one question is, if and when would you go and do
because they clearly may have a sentinel bleeding into the drain with this, with the presence of pancreatic fistula. Immediately when I get to the CTA, if the patient is stable, I can even consider
or pancreatic anastomotic leak. And so those patients, by definition, have an open communication to a luminal structure. And so
Straight to the OR after 2 months and had a complete path response. So it's a pretty, when it works amazingly well. But the other thing is, as you know, is most oncologists like to keep something in their back pocket, right? On the back end when folks recur. So they don't like to kind of, as you said, kind of use up all options. Because once you've given them FOLFOXIRI and if you've given them a biologic, then what are you left with?
I'm sorry to
Typically to
interrupt.
me-
Sorry, Jill, what time are we, do we come back?
We come back from this breakout at 6:21.
6:21. Okay, sorry to interrupt. Go ahead, Rohan.
Yeah.
I think Brendan was going to say something.
Yeah, I think we do the same thing. It's that 40-year-old with super bulky Mets at presentation. We are like, wow. And you're, it's almost like neuroendocrine tumor in the sense that there's this little islands of normal liver in the middle, and you're like, all right, we got to go for broke here. There's only one shot.
Yeah, no, I mean, I see
How
them.
about you
I see
thinking-
they're waiting for, saving our other agents. The other way to look at this is to hit them hard up front to try to sterilize as much as possible, because, again, I don't know if I'm interpreting the data wrong, but it looked like the survival benefit was fairly remarkable.
But I mean, what's the plan though, Rohan? I mean, it's hard. It's always hard for me because the question is, what are we trying to get? And I think, if this is a person who is unresectable, then, the question is, are you really thinking that you're going to convert them or not? Because
Well, and we know the data with conversion is not great, at least as far as I read it, right?
Period.
Because
It's not great, period.
It's not great, and the risk of
But-
risk of recurrence is so much higher in those patients anyway. For me, it's usually I'm dealing with rectal cancer with liver mets, and I'm trying to do radiation sparing regimens, and they're pretty much I'm testing them with chemo. So I would give them 2 to 4 cycles of FOLFOXIRI, and then try to do their liver complete out their TNT, and then try to avoid radiation in that case, because I'm looking for as much of a pathologic response as possible. But I do my own rectal resection, so that's why I can try to get away with that. But I'm trying to avoid radiation for toxicity in those patients. So that's kind of my thought.
Got it.
Are you guys doing anything different?
Yeah, it's hard. I think a lot of FOLFOX, if you're really trying to be aggressive, I agree about the FOLFOXIRI, but over the last 2 years, we've done a lot of pumps. So we're in the pump game, and we're looking at things differently. And it's amazing, how prior to pump, I would consider a patient, and I know I could get them resection. And now you get patients with the idea of a pump in your toolbox, and you say, well, I probably could have got them a resection, but you know what? I think I'm going to put the pump in because I know I can get a better outcome. And I could shrink these, and we know they have a more remarkable. It's interesting how pump changes your interpretation of these patients.
And just another question, since we're talking about pancreas over here. So first of all, just a shout out to Kathleen. I had a patient that I saw that literally I had no concept that this was, I think we just need to change all of our guidelines, because this was unresectable. Like, everything was involved. She is 38 years old, got a bunch of chemo, got radiation, etc. Kathleen did some crazy ass resection with a mesocaval shunt and all sorts of crazy stuff doing, and the patient's done really well. And I'm just sitting over here thinking, should I be doing this operation at all? Because I can't do that stuff. So Kathleen, talk to me.
Yeah.
Should I just retire early, 4 years earlier than I thought?
Just refer them all to Kathleen,
I
right?
know.
All the crazy ass stuff.
Yeah. No, that case was not easy. That was about as far into the root of the mesentery as you can go. It kind of gets to wet tissue paper that caudally, and we try to preserve the jejunal branch as it goes underneath, and then you're at this kind of crazy skewed angle that you're trying to sew to. So it can get pretty tense in the operating room, but thankfully it went fine with her, and she did great. So she's running around playing with her kids now, so she's happy. But
no, and I do this. I mean, honestly, with any of these cases, I try to send this to Kathleen because I really don't want to call somebody unresectable without at least giving. I mean, as long as they're doing well on chemo and stuff, obviously. Are you all using FOLFIRINOX as your neoadjuvant approach in these patients? Are you sequencing radiation before? Dr. Choki, is that right? What are you guys doing?
Yeah, we used I think phosphories was most thing that we used over here. And then follow with radiation. We try to complete all three if possible.
How about you, Jinhee?
Yeah, we always choose FOLFIRINOX for patients with good performance status. You know, I learned a lot of things from Doug Evans and Kathleen. You know, I read their publication all the time, even before I go to the OR. You know, a lot of time, I think they've built up a lot of experience before. You know, in my personal practice, I make sure I know all the possible techniques to reconstruct before I engage the patient with advanced cancer.
And are you guys radiating routinely
Yeah, not really. Maybe this is a major difference between Hopkins group and the Wisconsin group. We select patients for radiation. I would say if the artery is involved, I would favor a short course SBRT before the surgery. If it's only vein involved, I personally I would stay away from radiation. I just think the radiated vein is very, very hard, very, very challenging to handle during the surgery.
yeah, so we start with FOLFIRINOX and we monitor response. So we're looking at their clinical response, their CA19-9, what their tumor is doing. We haven't really found that the vascular relationships have changed much. If we are not getting any response, or worse, they get a little bit bigger, their 19-9 goes the wrong direction, then we switch them to GemNab. And we do radiate everybody. And we've actually, I drank the Kool-Aid. We love radiation, and we haven't had any troubles with it as long as you catch it in a window of time where it hasn't gotten to the fibrotic stage. So it helps you, especially if you have to take tumor off of arteries. You can get in the plane between the perineum and the arterial wall. And if they've been radiated, that is much easier to do than if they come in de novo just with chemotherapy. So we have a lot of experience with it, but you also have to be super careful, because if you damage a radiated vessel, then you're dealing with pseudoaneurysms, which is part of our topic today. So anyway,
that is exactly, I agree with you. That is exactly why we choose radiation for, patient with arterial involvement. It's much easier to develop the plane to get it into the adventitious level to peel the tumor out. But for vein, it's much more challenging.
So we think that everybody with vein involvement should get radiation in general, because everybody with vein involvement has arterial involvement.
Right.
What I mean by that is, I mean, y'all know, I'm talking to people who already know this, right? But I mean, just because it's not touching a vein, if it's on the, not touching the artery, if it's on the vein, it's obviously infiltrating that space. And this allows you to clean off the SMA. Now, we are admittedly using less radiation, and we've backed off. We don't do the 50 gray, we do 30 gray in 10 fractions. And we're not using SBRT as much anymore. I think that's another thing. We're using SBRT for the last few years because it's a cool thing to do, but we're certainly backing off that for a number of reasons. I think it does cause more intense damage to the blood vessels and also more intense fibrosis early on. And also the concept is that SBRT is for a small area. Well, that's a small area you're going to cut out anyway. The wider field radiation is the purpose to help the areas that the surgeon can't get. So it's kind of antithetical to what we're trying to do with regional control.
Ching-Wei, I'm glad you said that because
what's your timing?
I don't know if you saw, we actually published that finding. We looked at our SMV positive patients and we 5-color ink. So we looked at the SMA margin in those patients, and 50% of those patients had tumor on ink, not within 2 millimeters. So you're absolutely right, I think.
What's your timing now, Ching-Wei? I know it's changed, but
6 to 8 weeks, probably similar to what they're doing with
so it's still the same.
6 to 8 weeks after regular radiation. 4 to 6 weeks that we learned from the Hopkins group for SBRT, because we learned a lot from the Hopkins group about all their SBRT. So we move earlier on the SBRT.
Just a real quick housekeeping question before the fellows come back. Do you guys, when we come back and you start to talk about the topics, would you like me to show the questions as I did previously?
Yeah.
I'm asking the
Yes.
moderators. And then I won't go to the discussion points. We'll just go to the topics A, B, and C. That worked okay? Just housekeeping. Kathleen and Attasit. Good?
Yes.
Okay. All right. Right. I think they're coming back in about 5 minutes. 6:21, yeah. So about 6 minutes. So great discussion.
Yeah,
So Rohan's got the liver case, he's got the pancreas case, all set and ready to go for the faculty in between.
You know, it's my spiritual gift to make sure everyone's engaged.
Kathleen, what is your time frame in terms of operation in Milwaukee, and what sort of radiation course are you guys using? Are you given short course or stereotactic or full course?
So the timing of when we operate is somewhere between 4 and 6 weeks, ideally. And we are in the middle of a clinical trial with SBRT and standard fractionation 5.5 weeks. And we're probably about 60% through that trial. We haven't changed the timing, but we tend to go on the earlier side of what was discussed anyway. So anytime after 4 weeks, we start looking for an OR date. So, and we do the 30 and 10 on like your frail grannies that can't tolerate very much, you know, or they've really gotten beaten up through chemo and it's like they can't tolerate a whole lot more. And we're right now, the SBRT is reserved for clinical trial only. So, but we have an in-house trial for that.
And you guys are radiating everybody, regardless of resectability, resectable or borderline or whatever. Yeah.
Right. So the only ones we don't radiate is if we somehow can't get a tissue diagnosis ahead of time. So they may have a, you know, because obviously MedOnc won't treat them if they don't have a cancer diagnosis. So.
All right, Jill, do you want to do a broadcast? We have what, about 3 minutes?
Yep,
Like
absolutely.
That. So give them a 3-minute warning and then, you know, right at 6:20, 6:21, we'll bring them back.
Sure.
So.
Hey, Sabina, I have a question for you. Since you brought up the HAI, because we're, believe it or not, MD Anderson is thinking about it. You heard it here first. No. So you say you're using it more. So in reality, what proportion of patients? You're still talking about like single-digit % that you're using it in among kind of surgical?
Yeah, so probably over the last 2 years, we've probably done about 40 patients. Yeah. So it's still very selective in the patients that we're doing it. We're using it for cholangio patients. We're using it for colorectal mets as well. But yeah, Leipzig has done a great job along with Peter Allen coming down. They started it. I just helped them take it into a robotic, make it easier to place. But, you know, now Litsky working with the Angelica to start that consortium, they went from about 20 programs, you know, nationwide to about 40 programs in the last 3 or 4 months. So there's quite a buzz that's going around about HAI right now. And it's remarkable. I mean, we've had some significant responses, as many of you know. The one of the things I battle with now is we're using it, and I've used it in a couple of people, a young lady where it's all but gone away. She's got some small little things. And, you know, I kind of was saying I was going to go clear them, and everybody's like, no, don't do anything. So, and I don't know. What do you do? Do you sit and watch them? Do you wait? You just let it? I don't know. So I'm still trying to learn it myself and understand, you know, when to strike, when not to strike, and so forth.
Yeah.
The private oncologists hate it, just that you know. That's one of my challenges. They absolutely hate it, and they will not do it. So we can implant them, but they won't take care of it because it takes too much time and effort for them to use.
Exactly, time intensive. Absolutely.
Yeah. So flush and then do the infusions, it's really painful. So, but I agree with you. My 3 or 4 patients that are 8-year survivors with diffuse bilateral Mets have had HAIs.
All right, I'm gonna start to share my screen in preparation of the fellows coming back. And as soon as we bring them back, Pancreas team, you take it away. Okay.
Okay, do we have everyone here?
Okay, we got everyone, okay.
Like it. Okay. We can start with the topic A, early, less than 24 hours postoperative bleeding from Whipple with hypotension. We can start with group 1.
Hi, it's Mike from Toronto, speaking on behalf of the group. I think we were all fairly consistent with our approach. Within early 24 hours, most likely cause of bleeding. We were thinking about most likely maybe bleeding from the unsnit dissection or an IPDA, GDA that wasn't like where a clip or a tie fell off, or worst case scenario, maybe the portal vein recon fell apart, or the growth factor was too big and the patient got resuscitated in PACU and started bleeding from there. So diagnostic tests, we were thinking, well, for diagnostic tests, one is just resuscitation as needed, depending on their hemodynamic stability and seeing how they respond. And kind of following that, the segue is like, when do you decide to operate if they're quite unstable or they're requiring 4 units, 5 units, and it's very early, especially early, like in the first 12 hours, it gives you a very good incentive to go back to the operating room and seeing what's going on. If it's only 1 or 2 units and it's closer to the end of that 24 hours and you have some time and you're thinking about your operation and you're not really entirely sure, and you have time on your hands, then doing a triphasic with an arterial phase to see what's going on can provide a bit more planning strategy for creating an operative plan. And for intraoperative methods and techniques to ensure hemostasis, if going through the different causes for GDA, ensuring that maybe multiple different techniques, so a silk tie, hemolocks, and titanium clips, or some combination of the 3, or picking 2 of the 3. Also ensuring that you have proper length on the GDA. For the unsnit dissection, ensuring that you're using a good sealant device, or in addition to clips or silk ties. Making sure that you're taking your time and you're not rushing through it for sure. And then for the IPDAs as well too, ensuring that you have some good clips or a ligature device there, or ties as well. I think also importantly, before you go to the PJ, to look at the SMA dissection and looking at the IPDAs and ensuring that you are quite hemostatic before you proceed to doing the PJ. Furthermore, you can also have bleeding from the pancreatic transection margin. And so a technique that is maybe a bit variable depending on the staff surgeon is doing those cranial or cephalad and caudal pancreatic sutures that I always seem to cause more bleeding with intrapancreatic hematomas. And I think the other final point that we wanted to address was just before completing the case to have a very thorough check for hemostasis in the retroperitoneum and on the arteries that's been clipped and tied and off the SMA, and ensuring that you're quite satisfied with your hemostasis. And just overall, just having, especially first 24 hours, there's have a lower threshold to taking the patient back to the operating room.
It's good. We can hear from the group 2, and then we can discuss with the group 3 after. Group 2.
So I don't know, I might be group 1, but anyway, we start. So we discussed the cause of bleeding. I think it's very unlikely scenario as long as I experienced, but maybe just combination of the vascular resection or reconstruction, so around the SMA or anastomosis, or maybe poor hemostasis, or maybe patient got some medical condition like cirrhosis or as a background issue, or early use of tradol, so it can potentially make patient ooze. The diagnostic test is I think someone already described that it's just ongoing resuscitation, how much required, what's H&H, what's arterial gas and lactate, base excess, that sort of things. The treatment options, we usually try conservative unless the patient really unstable or sign of bleeding in the PACU. You got flank blood coming in the PACU and very tachycardic, and then in that case, I would take the patient back. Otherwise, just 1 unit of blood overnight wouldn't really facilitate to back to OR, because taking back the patient to OR is a big deal. It basically doubles the complication rate. So treatment option is basically conservative or rarely intervention. If it's really unstable, and then take back to the OR. The last question, the method and techniques to ensure hemostasis. I think the hemostasis is quite important before the reconstruction. The common site is along the SMA and IPDA. If you skeletonize artery, those tiny branches from right hepatic artery around the GDA can bleed quite a lot over the time, especially if someone need anticoagulation straight after the surgery. Otherwise, if we did a vascular resection, make sure the anastomosis is patent, especially on the posterior side. Other things like ganglion, celiac SMA ganglion can bleed quite profoundly. So we make sure the bleeding is controlled before the reconstruction. Those things we will take care of to make sure hemostasis is done.
Did we hear correctly that you think that the when do you decide to operate, you chose to go for conservative method first with the IR, and then choose the operation as a last resource?
Yeah, but I think it's very rare. I never seen the patient required IR within 24 hours. That's because usually that's vascular issues, and within 24 hours, the patient need to go back basically. But I never had this experience.
Okay. How about group 3? Group number 3.
You guys choose a spokesperson.
Okay. Yeah, okay. So group 3, we discuss basically the same things. The most likely cause of bleeding, we think that's also from a suboptimal hemostasis. Probably could be from the eosinotic process, the IPDAs, or from the sites of resection, the gallbladder fossa as well, or even from the sites of the anastomosis, the GJ or the PJ as well. So you have to be very thorough when you're constructing it, that there's no bleeding. And regarding what diagnostic tests are needed, we believe that clinical suspicion is very important in this case. The patient is hypotensive. So we will start resuscitating the patient, and if he's still in the same condition, we will have a really low threshold to send him back to the OR and reoperate him. And I think that that's the best option in this case. And what interpretive methods we would have used to prevent this complication. Basically, just really check out for any bleeding, be very thorough, checking those areas of major risk. And if, well, for the GDA, you can use a pedicle for it, but usually late bleeding more than early, and be very thorough also when building the anastomosis.
I see. Okay, so I think it's kind of like, you know, everyone kind of going the same page with the unique about the Whipple operation is that you go through a lot of section area and an operative field. You have to think about the steps of each step of each step of the operation that you're going to go through. Small blood vessels, arterial branches, and tributaries of the veins. Can go to like GDA stump, how you secure it. You can use clip and then the double techniques of whatever you prefer. Portal vein tributaries, hepatic vein branches, SMA tributaries, jejunal branches, IPDA that we talked a lot. Even pancreatic cut surface, gallbladder, fossa, or even PJ anastomosis, HA anastomosis, portal vein anastomosis that we did. Maybe Dr. Christens can add on some techniques about the, yeah, go ahead.
I mean, I think the only other thing that hasn't been mentioned so far is that along the IPDAs, if you ligate that tissue in mass, you have the potential for the tie to fall off, and you haven't individually ligated the IPDA, and then you're back bleeding right away. So that would be one thing. Resist the temptation to get a big wad of tissue along the SMA. So.
Yeah, I like to like thin it out until I actually feel the IPDA itself before we actually ligate it.
Right, and we doubly ligate all the major vessels. So the GDA is doubly ligated. If we're doing a distal, we doubly ligate the splenic artery. And I think, you know, between minimally invasive and open, your technique needs to really be the same. Whatever it is, it should be similar. It should be the same operation.
So for the fellows, I just think it's important that you're also hearing that the closer you are to the SMA is better. You don't want to take big wads of tissue, okay? And I know initially you feel like, oh my God, I got to stay far away, but the closer you are to the vessel, the better. Now, Kathleen, we just take this with energy. I just use energy right on the SMA, and then we just use large hemoclips at the end just to catch the advent tissue and just mark that area, because we usually radiate adjuvantly.
Mm-hmm. Yeah, we handle them a little bit differently because we do radiate in the neoadjuvant setting. And the other thing we do is if you have a very short GDA stump, because your tumor's involving it, we will put bulldogs proximal and distal to the GDA so you don't have flow through it, and we'll oversew it with pledgeted proline, because the radiated arteries can't really take a joke. So that's one of the tricks we do if you have a very short GDA stump. But in general, if you're able to, we try to leave a longer stump so you can have at least 2 ties on it. Or as they've mentioned, you can tie or clip, whichever your preference is, but we try to doubly do it.
Okay. Any other thoughts from other faculties?
You know, I just think one other thing that hasn't been brought up is the role of TEG or coagulopathy in these patients. You do need to realize that, especially if they're not stented, that they may be more coagulopathic than you think. So you don't want to rush back to the operating room without correcting coagulopathy. Right. And sometimes a TEG can be helpful in this circumstance to know what you're going to give back. The other part is the use of TXA. We will often use TXA in these patients towards the end of the case, but you need to have your factors present in order for that to work. So just remember that. And your anesthesiologist should be on top of this, especially if they're giving anything.
Dr. Jayaraja, for the TXA, do you do the bolus introp and then run them on the drip postoperatively, like the trauma patients?
We usually will just do it as a bolus intraoperatively. And my anesthesiologist actually almost routinely at the end of a Whipple will give like a little bit of TXA.
Okay, we move on to topic B. Can we hear group 4, please?
Sure. Yeah, so I'm Ben Motes from Atrium. Nice to see everybody. So as far as the first question, what is the most likely cause of bleeding? So I think the traditional teaching, and certainly what we see most often in patients with bleeding further than 24 hours out, it's usually several days post-op. The most common cause would be a GDA, pseudoaneurysm, and typically that's in association with a leak from your PJ. As far as what diagnostic tests are needed to diagnose that typically, depending on the stability of the patient, would be a CT angiography. Sometimes, especially in cases where you've done a venous resection, have a vascular anastomosis there. Sometimes getting a tri-phase scan is helpful because it can show you particular portal venous anatomy if there's concern for bleeding from that suture line. And then from there, we all pretty much agreed that we would be fairly aggressive about using interventional radiology. And if there is any evidence of a GDA, pseudoaneurysm, that we would be basically the next call would be to interventional radiology to go for angioembolization of that. And then as far as IR techniques, typically that would be coil embolization of the GDA, a particular problem. It just sort of depends on what you find. And then as far as your tests go, that initial CT scan that you get can help to delineate whether this is an intraluminal bleed versus an extraluminal bleed, because obviously that would change your treatment algorithm if it was like a stable line bleed from your DJ anastomosis or something like that. So those were our thoughts.
Okay, group 5.
I think most have been said so far. I think I would add for that we discussed also that one of potential sites of late bleeding would be the SMA surface and the stumps of the PDA and other small arteries there. Again, the diagnostic test, assuming the patient is stable enough, we were talking if and when to do CTA or go straight to angio. We did not, as far as we know, there is not like hard data, and it's kind of depends on the surgeon and what he thinks, and also the institution capabilities. And treatment option, then we agree. I mean, almost always it would be IR first. That's the main option. Sometimes other than coiling, if there is like a very short GDA stump, I saw sometimes that they use a stent graft in order to cover it and to preserve the flow to the liver. That's another option of IR. And I think he said the rest.
So I think one of the clinical concepts here is the concept of a sentinel bleed and not ignoring frank blood in the drain. You obviously never want to see this, but it's always in the middle of the night, and it's always an intern calling with, oh, all of a sudden there's blood in the drain, but it stopped. So your tendency is one to roll over and go back to bed and worry about it tomorrow, but that's your herald bleed, and you need to jump on that. So that's something that you have to pay attention to. And then the other thing with in terms of using interventional radiology, timing wise, the only time that we can get our interventional radiologists to do it ahead of a CT scan these days, and this may be institutional, we'll have to see what other people say, but is when they are truly hypotensive. But if they have like the herald bleed or something on that order, and you give them a little bit of blood and they respond, they will drag their feet and insist on a CTA. The problem with that is then when they do need something, then they have 2 dye loads. So, and when I try to always be around when this is going on, and I try to, if they are, hemodynamically unstable, I make them skip the CT part, because you know what you're going to do, where you're going to be squirting anyway. So, where the high options are for bleeding. So.
Kathleen, I
think
just
that's
put in the chat that, I really think that it's important to think about stent grafting in these people, because if the coils go into free space, so you just keep pushing them out. So you feel better for about 24 hours and then they tend to bleed. And we published this actually when I was at UT Southwest. And the second thing is just a little technical trip. I put a small clip right at my GDA stump when I do this. And that way, if that clip is migrated at all, it's a GDA blowout because it's not right on the common hepatic artery.
Yeah, and
Brendan here.
Nice little trick.
Yeah,
I wanted to comment on what Dr. Christensen is alluding to is her level of involvement. And for most of you who've experienced this kind of bleed, I would guess that your faculty are very involved in the middle of the night. A critical thing is how people manage it around you has a lot to do if you're physically present. So this is not something that you get to be at home for. I think when you have your first blood in the drain, you're going to be there, sit while IR does their angiogram, help advise them about how to manage it. The speed that they will get this resolved when you're physically present in that little IR control room, staring at them behind the glass, will be quite different. So just don't forget the importance of your personal involvement, the way Dr. Christensen alluded to it.
Yeah, I completely agree with Dr. Visser. Many of you are not necessarily going to be at big academic centers with really experienced interventional radiologists. And many of these people are going to be looking to you for what to do. And you need to be at the bedside. You need to be with them when these procedures are being done, for their support and also to guide them too. So completely agree.
the other thing is I do want to echo what Rohan said about stenting, but for even another reason, not in addition to the coils going wherever they want to go. If you acutely take out that hepatic artery, then you're looking at high potential for liver abscesses, and that is not a great place to be. It can be very prolonged and it can actually be fatal. So if your interventionalists have an option, you definitely need to stent it rather than knock out the whole hepatic artery. So.
But the only thing, Kathleen, is I do want to make sure that nobody feels like you should go to the operating room, because that's never going to end up well. And so I personally would rather take out the hepatic artery if you've got no option, obviously. Right. But you've got to stand there with the as Dr. Hagopian said, with the angiographer and say, I don't care, get across this. If you dissect it or if you occlude it, I'm okay with that. I'll take the fall. And then they're happy with that.
I think this is a really terrific discussion. And I just want to make one more point. We're talking about the GDA, but these pseudoaneurysms can come anywhere on the visceral arterial tree. And so that's one real advantage if you have the time of getting a cross-sectional image, of getting a CT angiogram, because if you look at the larger series, which are really only in the handful of dozens of patients with pseudoaneurysms, but that can be along the SMA, it can be along the left gastric, it can be along the gastropaploic, so sometimes when the pseudoaneurysm is there and it clots, you can have a false negative angiogram because all you're seeing is the lumen of the vessel. So cross-sectional imaging is very nice if you can do it.
Okay, I think with the respect of the time, we can move on to topic C.
Please.
Can we hear from group 6?
Yes. Hi, this is Mo from Hopkins. Thanks for the group for letting me speak. So for the most likely cause of GI bleed is still, it's either arterial pseudoaneurysm that's presenting as intraluminal bleeding. So the first on the differential is still that this is a pseudoaneurysm or an arterial bleed. The onset also kind of help with the differential. For example, if it's an early intraluminal bleed, for example, coming out of the NG tube, then most likely this is a staple line bleed from the GJ. The other two anastomosis can bleed too. You can bleed from the PJ or the HJ, although less commonly. Now for the diagnostics test, this has been discussed at length. Most likely you would do a CTA, especially if it's early on and you're suspecting that this is an arterial bleed. Later on, and EGD comes in handy just to diagnose whether there's a staple line bleed, or rarely far out, you could have an ulcer that's bleeding. But depends whether we're talking about a massive hemorrhage or a little bit of melena that's kind of presenting in a very insidious manner. And then for the treatment options, again, depends whether this is an intraluminal arterial bleed. In that case, then IR is the way to go. If this is indeed a GI bleed from either the anastomosis, then there's a role for EGD with endoscopic intervention.
I see. Have you thought about thinking about the other, for example, RBC TAC cell scan, nuclear medicine? Have you used that, or any good way to use?
Yeah, certainly. This is for later on. I think the problem with this is that it's not. I mean, it is sensitive, but it's not very specific, and it depends on the rate of bleed. So if it's a very slow bleed, you may not catch it with the RBC TAC scan. So.
Okay. Can we hear from group 7?
Yeah, hey, this is Patrick Slivy from Atrium Health in Charlotte, Ben's co-fellow. Yeah, so I have to echo almost everything that Mo said. Obviously, significant GI bleeding postoperatively. GDA pseudoaneurysms usually come in the setting of pancreatic anastomotic leaks, and so there's a direct communication into the lumen. And so these can present as brisk GI bleeds. And then, as he said, differentials always include any of the other anastomoses that can, anywhere where there's blood that you've transected across, there's potential for bleeding. And then, as he said, late, you always have to consider a marginal ulcer bleed in the setting of a patient that's had a GJ anastomosis or even a DJ anastomosis with risk for marginal ulcers causing GI bleeds. Again, the intraluminal versus extraluminal we talked about, the differentials we talked about, diagnostic testing. We tend to go for CT angiograms early. That tends to be the GI protocol. Here is CTA to identify source. With the new protocols that we've had very little need for tag red blood cell scan nuke meds, and we tend to go from CTA, and if there's an undiagnosed source, then to endoscopic evaluation. If after multiple attempts at diagnosis without an identified source, I think a tag red blood cell scan, if there's concern for ongoing bleeding, is especially if you think that it's a slow bleed. And then treatment options. I think everyone kind of mentioned IR and endoscopic therapy. I've definitely had the personal experience of actually needing to go back for surgical drainage of a pancreatic anastomotic leak that caused ongoing pseudoaneurysm formation, not at the GDA stump, but rather from pancreatic parenchymal pseudoaneurysms that were unable to be controlled. And so we had to go back and just widely debride and drain the area. And once we got adequate drainage of the pancreatic leak, the patient was able to resolve their recurrent GI bleeding, which was great. And that patient, Dr. we did stent the common hepatic artery, but we were fortunate in the sense that we weren't too worried about pussing out the liver because they actually had a replaced left hepatic artery. So kind of a nice case.
That's lucky. Yep. So I think we have consensus to, everyone thinking about the same kind of thing. So maybe Dr. Christian can take over the teaching point.
Okay, so, just the global picture, the International Study Group of Pancreatic Surgery defined post-pancreatic hemorrhage in 3 parameters. And just to kind of get it in your mind, we've talked about the timing of it. So is it early, within 24 hours, or is it late? Early implies a technical failure or coagulopathy, whereas late implies something related to pancreatic leaks or abscesses, et cetera, in the abdomen. And then what's the location? Is it intraluminal or extraluminal? It helps you decide how to treat and how to localize what the problem is. And then we've discussed this as well in terms of how much you have to jump on this and handle it. And is it mild? Is it something that, they drop their hemoglobin, point or two, but they're hemodynamically fine? Or are they, severely hypotensive and tachycardic and they need intervention yesterday, kind of thing? And so the study group defined these 3 parameters. and placed it into a grading system of A, B, and C. And basically the A has no impact in the care and the people get over it and go through their course as usual. The B, you have to adjust your postoperative pathway and you may have to intervene. And the C are the critical, severe, life-threatening, and you definitely going to have to treat, and it will prolong their stay. So just kind of a big picture view of how to think about these patients. And then one of the key things that many have brought up already in this discussion is prevention, prevention, prevention. And we've talked about not ligating IPDAs in mass. We've talked about doubly ligating vessels. And then if you can move to the next slide, one trick that most people know now, but this is you can see a picture of a Whipple reconstruction basically, and the pancreaticojejunostomy is on the right. The hepaticojejunostomy is on the left, and then centrally you can see right where that common hepatic artery and the GDA stump. And so you get a leak, it's going to pour pancreatic juice right over your GDA. And if you can go to the next slide, and what we do on every Whipple that we do is we take the patient's falciform ligament, we make sure we harvest it all the way from the umbilicus all the way up and over the liver and bring it down. And we actually put it in kind of a serpentine Y, and we take the right side of it and we wrap it over the SMA, and the left side we fully cover the GDA, assuming you have enough fat to do so. But it's one of these easy things to do. It can keep you out of trouble, and most people have enough fat in their falciform to do so. So just one of the tricks. So next slide.
Okay, so just to wrap up the teaching points for the 3 topics, the topic A, management of early postoperative bleeding. I think everybody kind of agree whether the patient has coagulopathy or technical failures or something that you did wrong or not right. So we have a low threshold to go to OR as a surgeon for the less than 24 hours bleed. For the topic B, management of late postoperative bleed, you have to think about the complications of operation, abscesses, fistula, erosion, aneurysm. And we tend to use more IR than surgery because it's more difficult to operate on that kind of timing. And IR techniques, everybody kind of agree that you need to be present, be there. And the first question you ask the IR to come in, they're going to say, no, no, no. You're going to have to keep bucking them to come in the hospital. You have to be there and the IR suite to tell them what technique you're going to use. You're going to knock down what artery you're going to take off, kind of that thing. The topic C for management of the intraluminal bleeding, the first and important things that to think about is to rule out extraluminal bleeding with whatever things you have to do for CTA or diagnostics testing. And we tend to use endoscopy more than surgery. And you have to be there in an endoscopy suite to tell them or to kind of stress them out. Same thing with the IR. Any other thought from the other faculties?
We do like the falciform flap too. I think it's really a great thing. Just remember, you can cause some serious damage as you try to tunnel that after you're done with your anastomosis. So don't disrupt your anastomosis as you're trying to do it. Kathleen, do you lay it first before you do your PJ behind this? I know John Martini does that robotically. I tend to pull it through after the fact.
Yeah, I do it after the fact. Yeah.
But as you're remembering, as you're entering the abdomen, we usually use a midline. Just remember to keep that falciform as long as possible. Just stay way up high. You can always thin it down, but it's hard to make it grow.
This has been fantastic. We did go a little bit over, but this is really been quite productive, and I hope that everybody had a really good time. In the interest of time, people can stay. I just want to thank all of the panel of the faculty. I also want to thank the fellows. Please look out for the evaluations that you're going to get. Please fill them out. We look at them. And I also want to do a shout out to one of your fellow fellows, Lev Bubis, who is your representative on education and training. He was part of our panel, so I know he's out there somewhere. So big shout out to Lev, because he was actually very instrumental in forming the small groups, no faculty, etc. So again, shout out to him. I'll keep it open. People want to continue some discussion points, but of course, in the interest of time, those of you who have to get out of here, we understand.
Thanks, Ellen.
Thank you, everyone.
Thanks.
Yeah, thank you. Thanks, Rohan, for all of your good points that you made. And
of course, I'm sorry. You can always tell me to shut up, Ellen, but I do love the talk.
Oh no, I would never tell you to shut up, Rohan.
This is awesome. Anything else you guys need, fellows wise, please reach out, call, whatever we can do to help, job wise, etc. Yeah, I know everyone's stressed about this, so please lean on us, especially if you're looking at things outside the traditional environment. Happy to help, okay?
Oh, and I see there's Lev. How are you doing? I hope that it turned out the way you envisioned it with us.
I liked it. Hopefully everyone else did.
On the evaluations, right? When we
Ellen, I'm gonna leave, okay? It's great to see you.
Thanks, Rohan.
Thanks. Bye, guys.
Any other comments from the fellows? Any other discussion points? We still have a couple of faculty here. Everybody's waiting for, well, maybe somebody else has a good question. I'll wait.
So let me ask this. The last case, was the portal resection a kind of distraction? Because nobody said anything about could that portal resection bleed? Everybody was talking about the GDA.
I'm not sure if Dr. Choke wants to take that, but my experience has been limited, I'm happy to say, but most of these bleeds are arterial, obviously high pressure versus low pressure system. Portal veins, it's, very, very low risk of it bleeding with a good repair. Dr. Choke.
Yes, for the portal vein, we just put a little bit to add on, just for you guys to add more discussion. I think it's more important thing about the portal vein is you check your growth factor. It's a low pressure, so not really tends to bleed. And then people like nowadays use a lot of coagulation products to put on and add on around that, either Flowsys or anything. I think with the thing that we were planning to add on, but we didn't have much time, was the late, very, very late complications of this portal vein. It could be like portal vein stricture or portal vein hypertension from that the reconstruction that you have to think about, like 3 months after Whipple operation, the patient come in with like GI bleed. That's you have to think about this complication.
Sure. Yeah, absolutely. And portal vein thrombosis, right? I mean, you can have a, post Whipple pancreatitis that leads to portal vein thrombosis, splenic vein thrombosis. And yeah, that should be part of your differential if somebody comes in with a late bleed. So very good thought. That was actually one of the topics that we had potentially picked, just so you fellows know, was portal vein thrombosis. But I mean, you saw how quick everything went. In the interest of time, we cut it down to just 2 cases. But maybe we'll talk about that one next.
Appreciate it. Thanks very much.
Thanks a lot.
All right, guys. All right.
Ellen.
All right,
thanks, everyone.
Have a good night. Good weekend, everyone. Thanks, Jill. Thanks, Margie.
Great job. We had a recording, so yeah, it went awesome. Have a great weekend, and we'll be in touch over email.
Very good. Okay. Thanks. Bye-bye.